and yet controversial issues in anesthesia today involves the management of cardiac arrhythmias arising in the operating room. It is my belief that a clear understanding of the way in which these arrhythmias arise provides a rational basis for their therapy. Recent advances in cellular electrophysiology have tremendously clarified the mechanisms by which these arrhythmias are produced. What you're about to see is an effort to illustrate these developments and to relate them to the clinical situation.
Of all the problems faced by the anesthesiologist, those with the greatest potential seriousness are cardiac arrhythmias caused by autonomic imbalance. The arrhythmias resulting from parasympathetic or vagal predominance have long been successfully controlled by the use of specific anticholinergic agents, which block the effects of acetylcholine on the cardiac cholinergic receptors. Arrhythmias due to sympathetic predominance, however, have been more difficult to control because of the lack of a specific agent to block the effect of catecholamines at the adrenergic receptors of the heart, the beta receptors. Recently, a specific beta blocking agent to pharmacologically correct the autonomic imbalance which produces cardiac arrhythmias during anesthesia. The manner in which cardiac arrhythmias arise from autonomic imbalance has been clarified by recent studies of the electrophysiologic activity of single cardiac cells. As with all living cells, cardiac muscle cells have a transmembrane potential of approximately minus 90 millivolts. This is known as the resting potential and is due to ionic gradient across the cell membrane, with a high concentration of sodium outside the cell and a low concentration inside, and a high concentration of potassium inside the cell and a low concentration outside. Thus, the cell is said to be polarized, with the inside being electronegative with respect to the outside. If an electrical stimulus is applied to such a cell to decrease the electrical potential to a critical level, known as threshold potential, the cell membrane quite suddenly becomes permeable to both potassium and sodium ions. As sodium rushes into the cell and potassium rushes out, the cell rapidly becomes depolarized. The transmembrane potential not only falls to zero, but even becomes slightly positive for a brief time, after which the characteristics of the cell return to normal and repolarization occurs. As sodium is pumped out of the cell and potassium re-enters, the resting potential is reestablished. It is important to note that the transmembrane potential of a cardiac muscle cell will remain at this level until an external stimulus again reduces the potential to threshold and the depolarization-repolarization sequence is again evoked. This is to be differentiated from cardiac pacemaker cells, which differ from cardiac muscle cells in an important respect. The cell membrane of pacemaker cells is apparently unable to maintain the potassium gradient. And as potassium is lost from the cell, a slow, spontaneous depolarization takes place until the transmembrane potential falls to threshold, leading to a depolarization-repolarization sequence similar to that seen in the stimulated muscle cell. But it is this phase of slow, spontaneous depolarization which is the basis for the automaticity of the heart. For it is the spontaneous depolarization and firing of the pacemaker cells which provide the electrical stimulus necessary to fire the muscle cells. Clearly, any alteration in the pacemaker cells will of necessity alter cardiac rate and possibly rhythm. Since sympathetic and parasympathetic influences are the most important determinants of the rate of spontaneous depolarization of pacemaker cells, it follows that most arrhythmias arising during anesthesia are due to autonomic imbalance. Sympathetic predominance will increase the rate of spontaneous depolarization, causing threshold to be achieved sooner, and an increase in the rate of firing of that pacemaker cell. Other factors that will increase the rate of spontaneous depolarization in pacemaker cells include hypoxia and/or hypercarbia, hyperthermia, and ischemia, all of which also cause a further increase in catecholamines, and mechanical stretching of the myocardium. In addition, the rate of spontaneous depolarization is selectively increased in the ventricular pacemakers only by digitalis, hypokalemia, and the current of injury resulting from myocardial infarction, in which damaged cell membranes cannot maintain the ionic gradients and act as pacemaker cells. Conversely, parasympathetic predominance will selectively decrease the rate of spontaneous depolarization of the supraventricular pacemakers, prolonging the time necessary to achieve threshold, resulting in a slowing in the rate of firing. The absence of parasympathetic influence below the AV node is due to the virtual absence of vagal innervation below this level. The intrinsic rate of spontaneous depolarization varies among the pacemaker cells depending on their location in the heart, with higher pacemaker cells achieving threshold more rapidly than lower ones. The important pacemaker cells of the heart are grouped together in the SA node, in the AV node, and in the His-Purkinje system. If conduction progresses unimpaired, each automatic cell below that of the pacemaker in control will be brought to threshold by the propagated impulse and not by spontaneous depolarization. But if conduction from a higher pacemaker is impaired, as by vagal stimulation, the cells of the lower pacemaker may achieve threshold spontaneously before the arrival of the propagated impulse from above, with the appearance of ectopic beats. If this impairment of conduction persists, the lower focus may take over as pacemaker of the heart, which will then beat at the slower intrinsic rate of this lower pacemaker. As with impulse formation, sympathetic and parasympathetic influences are normally the most important determinants of impulse conduction, with sympathetic enhancing and parasympathetic impairing conduction. Thus, sympathetic predominance both enhances spontaneous depolarization of all pacemaker cells and enhances conduction, resulting in a simple sinus tachycardia. Parasympathetic predominance, or vagal stimulation, selectively decreases the rate of spontaneous depolarization of the supraventricular pacemaker cells and impedes conduction in the supraventricular conduction system. Thus, the result of mild vagal stimulation is usually a sinus bradycardia. But if the degree of vagal stimulation is intense enough, conduction of the impulses from higher pacemakers may be slowed sufficiently to allow lower pacemaker cells to achieve threshold and fire spontaneously, resulting in vagal escape beats or rhythms. Particularly serious is the clinical situation in which sympathetic and parasympathetic stimulation occur simultaneously. There will be no change in the rate of firing of the supraventricular pacemakers, since the sympathetic and parasympathetic influences will tend to balance out. While in the ventricular pacemakers, which receive no vagal innervation, the unopposed sympathetic stimulation will increase the rate of spontaneous depolarization, leading almost certainly to the appearance of ventricular arrhythmias. Clinically, most cardiac arrhythmias arising during anesthesia and surgery are caused by sympathetic predominance. The more serious ones resulting when there is concurrent parasympathetic stimulation, as illustrated earlier. Sympathetic predominance may be due either to an absolute increase in the level of catecholamines or to a relative increase secondary to the removal of parasympathetic influences by vagolytic drugs. In addition, certain anesthetics are known to sensitize the myocardium to catecholamines, and usually there is some clinical factor which precipitates the appearance of arrhythmias. Since propranolol has a chemical structure similar to that of catecholamines, it can replace the sympathetic neurohumoral transmitter in the myocardial adrenergic receptor sites, the so-called beta receptors. Thus, such beta blockers deny entrance of the catecholamines into the beta adrenergic receptor sites and nullify their effects. When arrhythmias occur in the operating room, there is a logical sequence of steps which should be taken before drug therapy is contemplated. First, ventilation should be improved to enhance oxygenation and decrease the level of carbon dioxide because of the synergistic effects of hypoxia and hypercarbia with catecholamines on the pacemaker cells. Next, one should adjust the level of anesthesia, lightening it when cyclopropane is the anesthetic agent and increasing the level when a halogenated agent is used. In both cases, to decrease the level of circulating catecholamines and to minimize their effect on the heart. In addition, if the arrhythmia is accompanied by hypertension, this should be controlled by alpha receptor blockade using incremental doses of chlorpromazine to remove the myocardial stretching effect of the increased pressure on the rate of spontaneous depolarization of pacemaker cells. If at all possible, the precipitating clinical factor should be corrected, such as expanding blood volume, raising the body temperature, or cessation of surgical manipulation. But if these measures do not succeed in quickly restoring normal cardiac rhythm, restoration of autonomic balance should be accomplished by cholinergic blockade with an appropriate anticholinergic agent, or by beta blockade, If cholinergic blockade is indicated, atropine should be given in 0.1 milligram increments until the desired effect is achieved, as larger doses may precipitate the appearance of even more serious arrhythmias, including ventricular fibrillation. If beta blockade is indicated, propranolol should be administered in increments of 0.5 milligrams until the desired heart rate and rhythm are achieved. It should be remembered that the objective of drug therapy is to restore autonomic balance, not to provide total adrenergic or total beta blockade. Therefore, the indicated agents should be titrated against the response by small incremental doses. Whenever such therapy is contemplated, the central venous pressure and electrocardiograph should be monitored before, during, and after intravenous administration. If an inordinate rise in venous pressure occurs, the patient should be digitalized before continuing with administration of propranolol. Although at higher doses, propranolol is capable of causing myocardial depression, in the doses used for the therapy of arrhythmias, usually 1 milligram or less, the effect of propranolol is only that of beta blockade, without direct myocardial depression. Actually, when propranolol is effective in slowing a very rapid tachycardia, the result is an increase in cardiac output. For at very rapid rates, the heart and coronary arteries do not have adequate time to fill, and the effective cardiac output may be very low. Obviously, slowing the heart from such a rapid rate provides greater time for more adequate cardiac filling, and thus results in an improvement in cardiac output. To sum up, most cardiac arrhythmias that arise during anesthesia and require treatment are the result of autonomic imbalance. With a proper understanding of the impact of sympathetic and parasympathetic influences in the electrophysiology of myocardial cells, the judicious use of cholinergic and beta-adrenergic blocking agents to restore autonomic balance becomes the logical approach to therapy and represents an important contribution to the safe conduct of anesthesia in the surgical patient. For full information on fluethane, the Erst brand of halothane, please see the package circular. As with all agents used in medical practice, benefits and risks must be weighed against each other. The use of appropriate vaporizers is necessary to avoid the possibility of overdosage. Please note that safe use of fluethane has not been established with respect to possible adverse effect on the fetus. Among the liver dysfunctions applicable here are cirrhosis and a history of viral hepatitis. If fluethane is indicated in patients with markedly elevated intracranial pressures, appropriate measures should be taken to reduce the cerebrospinal fluid pressure. Ventilation should always be carefully assessed and adequate oxygenation and carbon dioxide removal ensured. For additional materials on basic concepts in adrenergic blockade, please see your Erst sales representative. Inderol should not be used in congestive heart failure unless the failure is secondary to a tachyarrhythmia treatable with Inderol, and should then be cautiously added to the treatment regimen. The period during which Inderol should not be given to patients on adrenergic augmenting drugs also includes the 2-week withdrawal period. It is potentially hazardous to inhibit sympathetic stimulation in the presence of congestive heart failure. In such situations, Inderol should be used cautiously, preferably under the protective cover of concurrent digitalization. At the first sign of impending cardiac failure, patients should be fully digitalized. If cardiac failure continues, Inderol therapy must be promptly withdrawn. If, however, the patient's tachyarrhythmia is being controlled, the patient should be kept on combined dosage and followed closely. If patients are receiving insulin or oral hypoglycemic agents, beta-adrenergic blockade may prevent the appearance of premonitory signs and symptoms of acute hypoglycemia. The safe use of Inderol in human pregnancy has not been established. In patients receiving catecholamine-depleting drugs, the beta-blocking action of Inderol may produce excessive reduction of the resting sympathetic nervous activity. Side effects have rarely necessitated withdrawal of Inderol. In addition to these side effects, isolated cases of erythematous rash, paresthesia of the hands, fever combined with aching and sore throat, visual disturbances, and hallucination have also been reported. In the reported instances of elevated blood ureas in a few patients with severe heart disease, it is suspected that the elevated urea levels were due to the renal status of the patient. In none of the several observations of elevated transaminase levels was there any clinical or laboratory evidence of hepatic dysfunction. Both patients with purpura were receiving other drugs in addition to Inderol. In the reported cases of reversible alopecia, a relationship to the administration of Inderol has not been established. Complete product information is available with this film and may also be obtained by writing to Airst Laboratories, 685 3rd Avenue, New York, New York, 10017.